Welcome back. In this video, we are going to review dumping syndrome. So, dumping syndrome is the result of rapid emptying of the gastric content into the duodenum and the small intestine. So, we have two etiologies. First, the volume loss. Because of the high osmolarity of the food that is being transferred into the duodenum, it will lead to a shift of fluid from the vascular environment into the intestinal environment, so the intra-intestinal space. This will lead to volume loss. Second etiology is because of the rapid passage of the food into the small intestine. This will cause a hyperglycemia in the blood, rapid glucose elevation. This will release insulin, and the effect will be hypoglycemia because of the massive insulin release. So the net effect will be hypoglycemia. Now let's review what causes rapid emptying of the stomach. Previously, medicine used to use surgery to treat severe peptic ulcer. So patients with a history of gastrectomy are prone to have dumping syndrome. Nowadays, no one uses surgery to treat ulcer unless very rarely. Now, for the patient, always check in the history while facing patient and you think of dumping syndrome, you will see a history of gastrectomy. The symptoms are related to hypoglycemia and the increased emptying, the volume loss. So for the hypoglycemia, we have altered mental status, confusion, tremor, and sweating for the low glucose or the hypoglycemia. For the increased emptying, it will lead to volume loss because of the fluid shift. So we will have hypotension, tachycardia, and some flushing because of the vasoactive release of some hormones, especially the serotonin. Also, we will have nausea, vomiting, abdominal cramps, and pain. Nausea and vomiting because of the fast and rapid emptying of the stomach, and also we will have lightheadedness because of the volume loss and hypotension. Also, there is diarrhea because of the hyperosmolarity. Remember, part of the symptoms is related to the vasodilation caused by the release of the vasoactive hormones like the serotonin. Some is related to the hypoglycemia because of the hyperinsulinemia, and some is related to the osmolarity of the high osmolar content that has passed into the small intestine. The diagnosis is made clinically from the history of gastrectomy and the symptoms. Most accurate study is scintigraphy. It will show a rapid emptying of the stomach. Now, we need to treat this by diet modification. Diet modification include avoidance of high carbohydrate in the diet, increase the fibers and protein in the meals. Also, small multiple portion of food daily to avoid these symptoms. What is important here is to differentiate dumping syndrome from allergic reaction and anaphylaxis, especially some symptoms overlap, like hypotension, abdominal pain, and the vomiting. First, the time is very important to tell us of the symptoms, the time between the two, the allergy and the dumping, and the history. Usually, patients with anaphylaxis, they will have immediate reaction after exposure to the allergens, while in dumping syndrome usually it takes up to 15 to 20 minutes postprandial to have the symptoms. Patients with dumping syndrome, they will have history of gastrectomy. On the other hand, patients with anaphylaxis, they will have a history of allergy. Not always that will be the case. Finally, we need to differentiate dumping syndrome from cannabis hyperemesis syndrome. Cannabis hyperemesis syndrome, as the name indicates, the history it will mention cannabis use. For the symptoms, sometimes they will say that the patient has symptom-free periods. So between the cyclic vomiting, they will have symptom-free times. The symptoms will improve with hot showers. Another hint, it might be mentioned in the question. For the treatment, antiemetics such as ondansetron. Remember, for dumping, there is history of gastrectomy.
So in this video, we are going to cover Mallory-Weiss syndrome versus Boerhaave syndrome. Both of them, they appear in the esophagus. Now, the main difference is the level of penetration in each one of them. So in Mallory-Weiss, we have submucosal tear of the vessels. In Boerhaave syndrome, we have a full penetration of the esophagus. For Mallory-Weiss, the causes are related to forceful retching or vomiting. Usually the patients are alcoholic, and sometimes they might mention heavy lifting in the history of the cases. Now for Boerhaave, we have also forceful retching or trauma that is related or that is causing the penetration. Now, for the symptoms, because in Boerhaave we have a penetration, then we will have a leakage of food and air into the mediastinum. The food will cause infection and bacterial infection. For the acid, it will cause chemical inflammation in the mediastinum, and this will lead to shock. And the air will cause pneumomediastinum, which means air in the mediastinum. For Mallory-Weiss, we will have bleeding because of the submucosal tear of the veins and arteries. The blood will go to in the stomach, and with acid, it will be digested. This will give us coffee ground emesis. Or we will have hematemesis, which means that we will have vomitus with blood. So hematemesis and coffee ground emesis. Sometimes we might see in Mallory-Weiss syndrome hypovolemic shock related to bleeding if it was severe. Usually this is not the case. Mallory-Weiss cases are mild cases and the bleeding is mild. So in Mallory-Weiss syndrome, we will have hematemesis, coffee ground emesis, melena, and sometimes hypovolemia in severe cases. For the melena, we need only 50 milliliters of blood to see melena. We'll discuss it further in the gastrointestinal bleeding video. For Boerhaave syndrome, we'll have septic shock, fever, and air leakage. In the following figure, I'm going to review how pneumothorax is caused in the case of Boerhaave syndrome. So the pleura, it has two layers, the visceral pleura and the parietal pleura. They join together at the level of the lung hilum. This area is a weakness. It will allow the air that has been leaked from the esophagus to dissect the two layers from the lung, causing the pneumothorax. So it will leaks between the two layers between the two layers and the lung. This is the etiology beyond the pneumothorax. Also, we might see pleural effusions. However, there is a sign because of the air crepitus and sounds in this syndrome. It is called the Hammond sign. It's crepitus and sounds of air heard at the level of the mediastinum. So sometimes the medical question, they used to mention this, the Hammond sign, it's air crepitus because of the air movement between the mediastinal organs. So remember this sign in Boerhaave syndrome. For the next step, we need to confirm diagnosis. So in Mallory-Weiss syndrome, we do a scope to confirm the diagnosis, to confirm the bleeding. Usually it's normal because the bleeding is mild. If it's severe, we see the bleeding, and here it's becomes therapeutic option to inject epinephrine or to do cautery to stop the bleeding. So in Mallory-Weiss, the EGD, the scope is therapeutic and diagnostic. In Boerhaave syndrome, because it's perforation of a hollow organ, this is very critical, and this is emergency case. So we need to confirm the perforation and to act rapidly. So we do an X-ray, the chest X-ray. It will show us either a pneumothorax, it means we have air in the pleural space, or it will show pleural effusion, it means the fluids in the pleural space, or it will show pneumomediastinum, which means air within the mediastinum. Also, we said on the physical exam, you will find Hammond sign. It's a crepitus sound because of the air leakage between the mediastinal organs. So this is important to remember. Now, because of the perforation, there is a risk to put an NG tube or to do an EGD or even to give barium swallow. So all these three options are wrong answers on the exam or in the clinical life because they will worsen the injury. In the case of barium, it will cause chemical inflammation. So what we do is we give a water-soluble contrast to confirm the penetration and to see the leakage of the contrast from the esophagus into the mediastinum to confirm the perforation. Usually, sometimes the cases, it might mention EGD, and post-EGD, the patient has fever and maybe Hammond sign or crepitus, and think then of perforation as a complication from the EGD, and then answer water-soluble contrast to confirm the diagnosis. Now let's jump to the treatment. So in Mallory-Weiss, because it is mild, usually most of the cases of Mallory-Weiss, it is mild bleeding. And remember, there is a history of vomiting or heavy lifting. And this will cause a tear force that will tear the vessels in the submucosal vessels, the arteries and veins will cause bleeding. It's mild, self-limiting, and it'll stop by its own. However, you need to give PPI to suppress acid in both injuries. Remember, in Boerhaave, you give it IV because the patient should be placed MPO, nail per os, shouldn't be taking any oral medications, so we give it IV. In Mallory-Weiss, you can give it IV or PO. The exams, they don't ask usually this specifically on the route of the medication. So you do EGD, it will help us in Mallory-Weiss to diagnose and to treat by epinephrine injection or cauterization of the bleeding arteries or veins. In Boerhaave syndrome, the treatment is to place the patient MPO to give acid suppression antibiotics to cover the infection in the mediastinum. It's usually severe and life-threatening if you don't treat it early, and to place the patient MPO and to consult surgery for surgical intervention. And remember, Mallory-Weiss, M, it's mild. And usually they mention patient with recurrent vomiting and alcoholic patient. Boerhaave syndrome, B, is bad. So it's severe, it's critical, you need to diagnose it early and intervene early. And for Mallory-Weiss, always remember that patients with alcoholic patients, they suffer from vomiting. So alcoholic, remember to rule out pancreatitis. If the patient has bleeding, remember to rule out Mallory-Weiss. And yet, because they are alcoholic, they might have cirrhosis, and you need to rule out variceal bleeding. We'll discuss gastrointestinal bleeding in the next video. We will go over esophageal varices and how to differentiate them from other causes and what is the treatment. Thank you guys for watching, and please support and subscribe to the channel. Good luck on your preparation.